Welcome everyone. Welcome everyone to this new EKPF webinar to talk about chronic kidney disease and families. It's very important for us as EKPF to provide children with kidney disease with the best quality of life. In fact, right now we are in a summer camp with children in the north of Spain, and it's been an incredible experience after 2 years without being able to do it. Today we have Stella Stabuli. She's Associate Professor of Pediatric Nephrology in the Aristotle University. She will deliver a presentation on CKD and families. And after that, we will have a debate table with Dorota Droz. She's representing the European Society of Pediatric Nephrology. And Tess Harris, who is representing FEDERG, the Federation of European Patient Groups affected by rare and genetic kidney diseases. So Stella, please, if you want to start your presentation.
Thank you very much. First, I would like to thank the European Kidney Patients Federation for the kind invitation and the opportunity to talk about this issue today, the chronic kidney disease in children and families. And during the next minutes, during my talk, I would like to explain some basic knowledge about chronic kidney disease and then discuss how this chronic kidney disease and the manifestation could affect patients and their families. So starting my speech, I would like to ask first what is chronic kidney disease, and I will try to answer this question as simply as I can. And if we want to say in simple language, I would say that chronic kidney disease is a chronic condition in which kidneys have a permanent damage. Kidney function will be reduced and gets worse over time. And CKD is also referred if you search in Google or even in books as chronic kidney failure. What causes chronic kidney disease in children? Of course, the most common cause of chronic kidney disease in infants, children, and adolescents are the congenital anomalies of the kidney, the urinary tract. Then, inherited nephropathies, as polycystic kidney disease, are the second most common cause, while glomerulopathies are usually at adolescence. And focuses on these two causes, which is the most common, I would like to show this red flag, which means that this is the most common causes, but they may first present with any urinary tract infection, which is a more common manifestation in children, and during further evaluation, this diagnosis may be revealed. If you want to see what is congenital anomalies of the kidney, this is a wide spectrum of phenotypes. There can be a small kidney, there can be only a genesis of one kidney, so what the child can have one kidney, can have one pleocystic kidney, or can have a posterior urethral valve, which means there is a stop in the urethra. So this affects both kidneys and the cyst. Then there may be some minor anomalies that are not affecting the kidney. It could be on the ureter, but then there is maybe some damage because of the obstruction in the kidneys, and we may have these images. For the second most common cause, the polycystic kidney disease, I want to show you what is a normal kidney, and this is a cystic kidney where cysts have been all around the kidney, so the renal parenchyma has been reduced, and so we have the chronic kidney disease. If we want to see numbers, we know from a recent publication, this is 2021, this is the European Society and the European Society of Pediatric Nephrology, the European Renal Association registry, where children with end-stage renal disease are registered. During the years 2007 to 2016, 1.1 children per 1 million children population between 0 and 14 years are presented with end-stage disease annually. If we want to translate this in numbers, we have around 500 children and adolescents with end-stage disease each year. And how to diagnose chronic kidney disease in children? Let's see first what are the manifestations. the most common manifestation is growth retardation. We will have an infant or a child that will not get weight, but also that will be very short. Then it's anemia, it's hypertension, this is high blood pressure. It may have some bone disease because of mineral and bone abnormalities. And of course, there may be fluid imbalance. This means that maybe the child cannot have enough urine, so that it will be fluid overload, or may, on the contrary, may have polyuria, so there may be some loss of water and also of electrolytes. And then there are maybe metabolic and electrolyte abnormalities, with most common abnormalities being those on potassium and phosphate. If we want to see the most common manifestations, I have to say that at early stages, most of the children are asymptomatic. But during the progression of disease, the hallmark issue is growth failure, especially if the disease presents during infancy. There may be poor appetite and chronic nausea. There may be frequent headaches because the child may have high blood pressure. There may be puffy eyes or swollen foot and ankles. There may be frequent urination, or in children older than 5 years, nocturnal enuresis or nocturia. There may be rickets or bone deformities or even bone pains. There may be anemia, and the child may have pallor because there may be a decreased production of red blood cells. There may be fatigue, and the child may be not able to concentrate, or even the children may have dry and itchy skin. But focusing on growth failure, I want to show this the growth chart. We all know the growth charts because of the child, where we are following the growth of the child. And you can see that this is the curves. Usually the child has to be between these curves, but a child with chronic kidney disease may be below these curves both for height and weight. And actually what we know, it is very important even for future health, is that about half of the children with chronic kidney disease may not be able to attain an adult height within the normal range. So they will be short, with many consequences on their well-being and psychological health, but also for other complications for their health. But what may cause this growth failure in children with chronic kidney disease? This is because they have mineral abnormalities, but also bone abnormalities. They have high phosphorus levels in the blood, and these high phosphorus levels may draw calcium out of the bones into the blood, causing the bones to weaken. They may have an imbalance of sodium, potassium, and acid base, and this is called acidosis, which acidosis results in moving all the energy that the child will use to grow to correct this acidosis. They may have decreasing appetite, which may lead to poor nutrition and slower growth. They may have decreasing production of erythropoietin. This is an hormone that is produced by the kidney, and this results in production of red blood cells. So if there is kidney failure, this reduced production may cause anemia. They may have polyuria, which results in dehydration, but also in losses of minerals like sodium. And although sodium could not good in excess for our health, if we don't have sodium, this is also important because we cannot grow. And then they cannot use correctly growth hormone. How we can diagnose chronic kidney disease before birth? Maybe with an ultrasound, where we can find these abnormalities of the kidneys and urinary tract. Then, as the child grows, there may be usually various signs or symptoms that I have described earlier that may lead to the diagnosis of chronic kidney disease. When the child has symptoms, then a pediatrician may refer the child to a pediatric nephrologist who may order different tests. Some of the tests are a urine analysis, blood tests that may check for kidney function, some imaging tests like ultrasound, and finally, sometimes we may do kidney biopsy to get the diagnosis. What is the meaning of the term chronic kidney disease? Because we have reduction in kidney function over time, the stage of chronic kidney disease changes. When a person is first diagnosed with chronic kidney disease, she or he could be at any of 5 stages, which I'm going to describe just in the next slides. But in order to have a measure of the stages, we need to have some number. And this number is glomerular filtration rate, which help us to determine renal function. And we usually calculate glomerular filtration rate from the results of creatinine and other factors, which is usually age, gender, and children height. The result of GFR is the best way that we determine our stage of kidney disease. And here we can see the stages of kidney disease. There are 5 different stages. We have stage 1, where GFR is between 120 and 90. This is a normal. This is how normal people, the kidney function of healthy people. Then we have stage 2, which is an early stage kidney disease between 90 and 60. Then between 60 and 30 is stage 3. And from 30 to 15 is stage 4. This is a wide range where we have a medium impairment of kidney function, and below 50 we have kidney failure. How we can treat chronic kidney disease? Actually, there is no treatment we cannot fix the damage, because chronic kidney disease is considered a permanent kidney damage. However, what is the goal of medical practitioners is to help children to slow down the progression of disease and, of course, the complications. So the main objectives of treatment are treatment of possibly, if we can, the condition that is the underlying cause of chronic kidney disease, so that the disease is not going to progress, alleviating the symptoms, the poor appetite, the anemia, the high blood pressure, and then slowing down by targeting factors that may aggravate kidney disease. And for this, we need proper nutrition, and sometimes we need several medications, like the ones that they lower blood pressure. When this child reaches stage 5, then we should discuss, but this is always discussed, not discussed, then we should start dialysis, or we have to go kidney transplant. Of course, the discussion about transplant or dialysis may start earlier from stage 4, so that we prepare the patient and the family. Usually, dialysis is needed when we have lost when only 10 to 15% of the kidney function is left. And it's not the number exactly, because any number below 15 GFR, we may start dialysis, but actually it's because how much symptoms the child will have, such as nausea, vomiting, swelling, and fatigue, how she or he can count with these symptoms. And sometimes, even if asymptomatic, there may be a high level of waste in the body, which may be toxic, so we should start with dialysis. Whether we have to start with dialysis or transplantation, of course, always transplantation is the best option for a child. And transplantation, it's the cure. It's the best treatment for all children with end-stage kidney disease. And actually, if a living relating donor is found, then we may go for transplantation preemptively before we start dialysis. Otherwise, we start with dialysis until a kidney donor becomes available. Regarding dialysis, there are 2 kinds of dialysis. This is one option is hemodialysis, where a dialysis machine and a special filter, which is used as an artificial kidney, or a dialysis as used to clean the blood. And of course, this has to be done at the hospital. And the other option is peritoneal dialysis, where the inside lining of the belly, the peritoneal membrane, is used as a natural filter to filter the wastes out by means of a cleaning fluid called dialysate. And this is washed in and out the belly in cycles. And this can be done with machines at home, and maybe sometimes this is very friendly for the well-being and the quality of life of children. Who is involved in the medical care of a child with chronic kidney disease? Of course, is the pediatrician, who will continue to oversee routine health care, including vaccinations, but also the pediatric nephrologist. But sometimes, especially for children that they have abnormalities of the urinary tract, we may need a pediatric urologist. We also may need a psychologist, a social worker, a dietitian, a psychotherapist, And of course, the parents, that they will have to work close with the parents and the patient in case of adolescents. And of course, we have to cooperate with the school teacher, with the friends, with the community in order to be effective. So actually, it is a teamwork for the medical care of a child with a chronic kidney disease. And let's come to the question, how chronic kidney disease would affect children and families. What I want to point out that chronic kidney disease is a chronic kidney disease. This induces stress both to the family and the child. Then the reduced removal of wastes like urea and creatinine in the body can slow down, and we know that very well now, the brain function, the nerve and brain function. So we may have impaired brain development. So on one hand, the stress may result to negative self-image and relation problems. Then the impaired brain development may result in learning problems, behavior problems, difficulty in participating in school activities, concentration deficit, and slower attainment of language and motor skills. And this is more severe when chronic kidney disease is starting early during infancy, because these early stages are important for developmental, for brain development. What is the goal of managing CKD targeting in the child and family? Our goal is to provide appropriate treatment so that the children can attend school, graduate from high school, and go to the college or university. And the main challenges in the child with CKD is to fit at school, to deal with this low self-esteem, how to make friends, to be physically active, to follow treatment, and prepare, of course, this child to enter the workforce. But before going to the next slides, I would like to show you what is very, very, very easy, very well described in this child. This is a child that she has a peritoneal dialysis catheter. What is the psychological profile? These children, they have low self-esteem and social ability. They have behavior problems, they have internalization problems, and they have academic and cognitive function. So they are a real challenge. And in order to deal with this problem, the first thing that we should focus is self-esteem. We should empower these children by giving control and responsibility of their own care as possible. These children, they have to learn about disease and about their medication, including doses. They should encourage to take active part in their treatments, and their parents and guardians, they should allow to their children, should be less protective, and they allow the children to participate in treatment and decision making. For school attendance, we should cooperate with school administrators, teachers, and classmates, and we should educate the community and inform about the effects of CKD. And they should be aware, they should be educated and aware that children with end-stage kidney disease may miss school each week because of dialysis or medical appointments. Regarding friends, it is actually a very big challenge, because children with chronic kidney disease, they could not fit with other children because of their short stature, but also because sometimes they have a delayed mental development. Then for those children that they have a transplant, there are other challenges, because a lot of medications have side effects. They may gain weight because of steroid treatment. They may also have acne or facial because of gain of medications. And this may result to lower self-esteem and inability or difficulties in making friends. One very important aspect, and this is that we should focus, is participating in physical activity and sports, because many times these children are inactive, of course, because their illness may not allow them to have the energy to participate, but also because parents are very protective. And actually, children with chronic kidney disease should be encouraged to participate in physical activity, including exercise and sports, because exercise has physical and physiological benefits, but also parents and guardians should be instructed to limit the activities of children only if the child needs to, and this should be instructed by their doctor. One thing that I want to point out is that one of the benefits of kidney transplant is that most children with a kidney transplant can exercise, and they can even compete in sports. Finally, following treatment regimens, children with chronic kidney disease may need to take multiple medications, eat a specific diet, And this is very difficult sometimes for younger children, but even more difficult for adolescents. And we have to focus on ways to improve adherence with combination of higher education, motivation techniques, and of course, cooperating with psychologists to improve behavioral skill methods. There is still much more challenges when it comes to adolescents, and this is my final slide, with an adolescent dealing with adolescence with all this hormonic and transition period, being on hemodialysis with older people, wanting to follow their other young and make friends, and of course, thinking of himself as being old in many times. And I'm going to stop here. I would like to thank you very much for your attention, and I'm open, and we're all open the panel for questions. Thank you very much.
Thank you, Stella. It was great. Great presentation. Thank you for doing it and for explaining it so well and so complete. I do have a question, and I'm not sure if you have included it in the presentation, but how can this disease affect at an economical level the family? Because there are different ways in which it can affect, and it may also be important.
Thank you. This is very important because it usually affects the family, because even if they have some help from the health insurance or from the government, sometimes they cannot work because the mother has to stay behind to take care of a child that then needs to be very frequently in the hospital or following dialysis in case when they have to go to stage kidney disease. And then there is a lot of facilities for children with stage kidney disease, but not for those that are in previous stages. So even in previous stages, they may have morbidity, they may need to go for hospital visits, or even they need to be hospitalized because of the underlying disease. And I don't think in many countries there is so much economical support for these early stages. So again, this is a huge problem for the family, because at least one member needs to stay with the child usually.
Okay, yeah. And I think, thank you, Stella. And I think it also was very important what you mentioned about how it can affect their educational level, right? Due to the different, so I don't know, how are the different ways in which it can affect their educational development at a school?
Yes, this is also one of the most important aspects to have to focus, because one part is when you have when an infant starts, when you start with chronic kidney disease of an infant, this may affect your brain development. And we have many publications about how chronic kidney disease can affect brain development. And although may not severe, they're not mentally retarded, there may be they have some deficit compared to other children. So this is a barrier to their higher education. Combining this, of course, with many absence from school and the barriers when they go to end-stage renal disease, or maybe some economical barriers, this means that these children may have less opportunities to go to higher education. So this is a very important thing that maybe we have to focus to policies to help these children to have equal opportunities.
Thank you, Stella. Yeah, very important. And now we're going to open our debate table with Dorota Droz and Tess Harris as well. Maybe you want to start off answering some of the questions that I just asked Stella, or maybe you want to add something. Maybe Dorota?
Yes, thank you. So I'm also working with the children on dialysis and with CKD. So we also see in Poland many difficulties. Also the economical issue, because as Stella already said, the parents, mostly the mother, has to take care of the patient, and there are also the costs of many medicaments of coming for the control to the hospital, for sometimes even for rehabilitation. So I would say the whole family life is disturbed, And what I would like also point out that as we see the healthy children in these families are also involved, because there is so time consuming of parents, the care of the sick child, that really many healthy children in the families have also psychosocial problems or problems in the schools. So of course there are different policies in different countries, I think, but for example, in Poland, the parents receive some money from the ministry, but I think it's still not enough, and there are still not enough specialists like psychotherapists or dietitians, or even social care for these parents.
Yeah, I think you're
In
right.
some,
It's like a multidisciplinary approach that we needed. That's right. And I think it's very interesting what you pointed out about the other healthy minors. When we talk about families, we tend to speak about parents and carers, but not also their maybe brothers or sisters. Yeah. And Tess, please.
Yes, thank you very much, Stella. That I think you presented the issues incredibly clearly, and you gave us a bit of a framework as well for thinking about in a holistic way about how we can care for children and by extension their families, with bringing in, of course, the psychosocial elements as well as the clinical. Just there was one thing that a couple of things that I was thinking about. One is a topic that we discuss that comes up often, which is a transition, which is probably no surprise to you or Dorota. And it's discussed regularly, and the issues around transition I think are pretty well known. And in some countries there's been observed a loss of transplants at transition, because of the shock to those young children of becoming adults and thinking they're invincible and not coping with moving into the adult world of kidney disease. But I was looking recently at the guidelines, and I noticed that the last guidelines were in 2011, which were ISPN guidelines, the international guidelines. And then in 2019, the European Reference Network for Kidneys, the ERGNet, did a review and published it of transition they did a survey of the ERN centres to, first of all, ask what model of transition people were using. And these are expert centres, not just, so, you'd expect them to have a high level, high standard, and also to discuss the barriers and obstacles. And it was noted in the report that although there were some examples of great practice and some great models of transition in place, there was a lot of inconsistency in implementation, and also that one of the big barriers was resources. That they weren't, even though they had the desire to do transition to the highest possible standard and perhaps had a particular model or process in their minds, they weren't able to actually do it because of resources. And this is really a Europe, something that should really be brought to the attention of the European policymakers, I believe, to ensure that these children are getting the best possible transition, because apart from the psychological issues, if a child who loses a transplant and has to go back to start again on dialysis and wait for another transplant, there's also the economic cost of that to the society, and the knock-on effects on their families again, who just felt their children were settled and stable, and then find they're having to care for a sick young adult. So that was number one. So I wondered if you had, I can go on and talk about the other one after we've discussed transition, perhaps.
Yeah, sure. I don't know, maybe Estela on transition and everything Tess has mentioned.
Well,
For example, in Poland, we started the program to have this transition process more official. And on local level, we cooperate strictly with adult nephrologists, and we simply prepare the process, and so that at least the patient have a specialist and a date for the next control as an adult. And of course, we prepare as well as we can, all the lab tests to prepare the family that they will be another, I would say, type of care, because with the quantities of patients in adult centers, there is no possibility really that they receive similar care like in pediatric centers. Yeah. That's.
Do you think
Yeah,
there's
this
a
can
need
really
to
mean a big change. Yeah.
Yes, they have
yeah.
huge numbers of transplanted patients, of patients that see 30, 40 patients a day. So sometimes they feel like, I don't know, a number, not really a patient. And when we have, for example, in a pediatric dialysis center, 10 patients, they are really like in family. So after years, they come to us 5-10 years later to say, oh, thank you very much. I have a child, I have married, I have job, something like this. And,
actually, the problem is there's no European policy in most countries. There are no policies. So pediatric nephrologists, we try hard to transit our patients in the best way. But then I think this is the problem. The barriers are because maybe one of the barriers is that we are very protective as pediatric nephrologists with the family. So we treat them, the families and the child, like child. So they never grow up. And sometimes when at the time of transition is too difficult for them. But actually, even if there is these guidelines, then in our meetings we'll discuss for sometimes from models of transitions. So there is some models that are there. I think there is 1 or 3 programs that are running. One, I think it's 2 in UK and 1 in Australia as pilot studies in order to find what is the best model of transition. But I think this is a very under-investigated area. And actually, I think all the barriers and all this transition and the point of view of the families, of the adolescent himself, of the adult patients, adult doctors, and the pediatric doctors, it could be a part of another webinar because I think it's a huge area of discussion where there is no less guidelines or standard of knowledge and more questions to be answered by discussion in a way.
Yeah, thank you. I just feel that though it has been endlessly discussed for some time, and I remember going to an ESPN many years ago in Belgium where they were doing some research into the best models of transition, and I just had the feeling it just hasn't moved on enormously well as quickly as one would have liked, and whether it's time to have some sort of a consensus, whether I don't know who would lead that, whether it needs to be international, or whether it should be perhaps ESPN could take the lead in that, to at least bring everyone to the table, including of course the adult nephrologists, because they are at the receiving end, of course, of the patients coming in, of those children coming into their centres.
You are right, although we may not have the scientific evidence, at least we need a consensus, and I think this should be in European level, because I think we're very different than Africa or Asia or even the States. So I think maybe we'll have to work together, patients, pediatric nephrology, ESPN, ERA, in order to have a consensus of how to deal with this important issue. but I think at European level it would be more, because we have to see the particularities of our area, because even in Europe we have different levels of economical countries that are more powerful, have a better high income. So at least we can, I think, at the first stage we have to see it at European level.
Yeah, I think that's what we should claim for, right? To have these coordinate and these individualized at the same time studies and health. I would like to ask a question that we have been asked, and it is, what is the percentage of genetic kidney diseases at children? Maybe Tess, you can answer this one.
Mm-hmm.
Well, I read recently that it was 75% of pediatrics and about 10% of adults at the moment have a genetic have CKD from a genetic cause. So a very high level, obviously, in children. So if there are 500 presenting every year,
yeah,
that's a lot, isn't it?
Yes.
Mm. That's high percentage.
Mm.
Okay. Well, we have studies. We've talked also that usually in the families, the mother has to reduce hours or even stop working in order to take care of the minor. This, of course, increases the dependency of parents, of kids on parents, and family plays a very important role also in how a child copes with the disease, how he adapts or she adapts to the disease. Which are the burdens that the family has to bear during this chronic kidney disease during the infants and the adolescents? Stella, yes, you can start.
Yes. Well, I think having genetic test availability, it will be a good step, because okay, the congenital anomalies may be diagnosed even with an ultrasound, a prenatal ultrasound, but there is a high percentage that needs to be diagnosed with genetic tests. So that genetic test availability around Europe is another important issue for these families, especially those to have an early diagnosis for the rare disease part, where new therapies are coming. So we may have less children on end-stage renal diseases in some cases. This is a way of screening.
Or Tess, do you want to add something on this?
What do you mean about the barrier for parents?
Burden? I was meaning the burden of families.
Because I had problems to hear you, so.
Yeah, sorry. We were talking about how dependent children may be of their families, of their parents. So which burdens the family has to deal with. We've talked about economic problems or stress, dependency.
So I would like to maybe to share my experience that I have many families when the sick child was treated quite like a healthy one. So, of course, the child had to take the medicaments, the drugs, but also to follow the rules, to attend the school, if of course it was possible. And in these families, I saw that the children really could grow up and take responsibility. And many of them have high schools or have a job. And in families, when their parents were so much overprotected, like Stella said, they were much more problems afterwards, especially at adolescence age, when boys wanted to be not dependent like others, and even they were really different problems. The barriers are so many, economical, the social life, also for parents, not to have the free time, not to have the other relationships. If the really sick child needs so many hours of cares, yes. So there are at so many levels that the life for the family is really very, very difficult.
Yeah, and thank you for sharing. I think it is very important, and it can help other families, like how you can treat the kid not only as a patient but also as a kid, as with their rules and their life, the school, everything that involves a family, right? Tess, I think you were going to speak.
Yeah, I was reflecting on care coordination, or rather the lack of it, because these families, particularly with the syndromic conditions, will not only be seeing a kidney doctor, but they might be seeing an eye doctor, or someone dealing with cognitive issues, physiotherapist, and they have to do all that care coordination themselves, sometimes traveling long distances, and that's a cost burden, time burden, particularly these days. And they struggle with, sorting out all the appointments and dealing with different hospitals, the communications between them, and a majority of those conditions will not have a designated care coordinator. They're common in some countries for mental health, and also for highly specialized conditions where they've been able to get some additional funding for care coordination, which is sometimes done by a patient organization. But most of those parents, and it's often the mother, are doing it themselves, and that can be a big physical and mental burden on them, and a frustration. And then there's often the issue of emergency situations, or perhaps in a different part of the country, something happens, then going into the local hospital. That hospital has no knowledge of that condition or no specialty, and that mother or father doesn't know who to call, so that the doctor who knows about the child's condition can speak to the local doctor, and that sort of thing. And we really do need, it's talked about a lot in the rare diseases, and I know a lot of the countries have national plans which include care coordination, but it's taking a long time to get it embedded into the clinical pathways. So we shouldn't underestimate the degree to which those parents are coordinating the care of those children right across that journey.
Yeah, and it's something to value, right? How they're coping also with that. I think, Tess, you had another question.
Oh, yes. So my second point was, apart from the call for some updates and transition, was is it time that we had something like a multidisciplinary statement, a position statement, that could be put out? It would require some time, obviously, to bring people together, but in a round table, and some funding to do it usually, but pull together the various disciplines involved in caring of children with CKD, and the families and parents and patient representatives, to publish a joint position statement, which could be perhaps in NDT or one of the journals, to raise attention to all these issues, the issues that Stella has so clearly articulated, and the additional discussions that we've been having as well, and really start to make a bit of noise about this neglected area, and the inequity that we know exists not just in ability to transition, but also possibly even access to transplantation or actually access to home therapies. You know, we could bring in the whole life of these children and young people with CKD.
I think you are absolutely right, Tess. We need to raise awareness and to see it from the point of view of the patients, not only from the medical care, but from the issues that are around the family. If they don't live in the capital, if they live in a small village, if they have a rare disease, if they have a dialysis, if there are so many issues. And I think we have to care what's the problem, and to see it not only from scientific point of view, but from this holistic view that we propose. This is absolutely correct. We have to do things together and raise this awareness to the policymakers to make this noise, but to start thinking some policies to help these families, because there may be more and more, and some are underdiagnosed, but some others, they are suffering, and we haven't pointed out that is even the crisis in the families. There are couples that are divorcing because they cannot deal with all these problems. Some of the couples, they're getting more close together, and then some other families, they are splitting, and this is another problem, another issue that they have, these children, they have to deal with.
Yeah, I think this was very interesting, the point to have this multidisciplinary approach in which if everybody communicates, right, we can provide this better care, this better quality of life, not only for families, especially of course for children. I don't know, Dorota, if you want to add something on this point.
I strongly agree that we need this transition policy published together. And covering all these topics because there are so different levels and problems and yes, topics to discuss and to really disseminate this knowledge. We know directly cooperating with the families, because so, for example, we are lucky we are a specialized hospital, so we can cover many specialistic problems and cooperate this therapy. But of course, there are different centers and long distances to the center. So
yeah, different issues.
Different issues.
Okay. Well, I think this was absolutely interesting. I think we could have very different webinars on very different topics that have come out here. We're drawing to the close of the webinar. I want the three of you. It has been super interesting. I think debate for many questions. I also want to thank you all for the things you do, for all the effort you put in this care, this better care for families and for children. I know you do very well in all your different perspectives. Thank you very much from the European Kidney Patients Federation for helping us carrying out this webinar. Thank you for everybody that is watching this educational webinar and that is listening to us and to the questions that we have. I don't know if you want to add something.
Just to thank you. I think this was a very good start, so that we have to patients and doctors, at least for the minors, start talking together. Thank you so much for inviting us.
Thank you.
It's a great idea. Thank you very much.
Thank you. And we'll